Well, good afternoon. I know it is getting to be a long day and appreciate you hanging in there for some, what have been for me, some pretty interesting conversations in the course of the day. So it's been great to be part of this discussion so far. Have any of you ever taken media training? So I see some head nods. And they tell you that no matter what the question is, you give the answer you want. Well, that's how I felt about my presentation title. And so I sort of redesigned, first intentionally in preparation, and then secondly on the fly here today, because with each presentation I felt like I wanted to update my comments. So the first thing I want to mention is that I think talking about governance is really important. I want to talk about that in the context of HealthPartners, so you know who we are. The first two things really important: not-for-profit, consumer governed. Consumer governed is a big deal to us. We were created out of the credit union co-op movement 50 years ago, when those credit union leaders looked at why their members were in debt, and they found out the reason was health care. And so they looked at, could consumers create first a prepaid health plan coupled with a consumer-led delivery system? And so those are our roots. I think probably no set of roots could be more closely aligned with the triple aim than people wanting affordable health care and wanting it for themselves and their families, in the quality and delivery system approach that worked for them. We're big now. We're a little bit like Geisinger in the sense that we aren't, all our members are not users of our own delivery system. So we have about 1.5 million members of our medical and dental plans, but only about 35% use our delivery system. And only about 35% of our delivery system patients come with a HealthPartners card in hand. So we're involved in a multi-payer environment, but we have the nice advantage of having a denominator to our work. We have about 1 million patients, 1,700 employed physicians. That number's about doubled in the past year and a half as we merged with Park Nicollet. So I'm still experiencing the exhaustion that comes with spending a year of post-merger activity. And then we do a lot of dental research. Interestingly, there's not as much dental research going on, at least in our region of the country, and so we're one of the few organizations working there. And as our dental leaders say, the mouth is part of the body, and so are the teeth, and sometimes we think of them as separate. So I note our Education and Research Institute, and again, we're going through a merger. So that's the background. I note mission, vision, values. A couple of things here in mission I would like to call out that are new for us and that have to do with a couple of messages I'd like to leave today. First is to improve health and well-being. We're starting to think we need to do a better job of caring for and treating whole people, not bodies, not medical issues, but mind, body, and spirit. And so we know there's a whole world of opportunity for us ahead to be more effective. The second is in partnership. The number one partnership I wish we would focus on is the one that we have with our patients and our members across all our institutions. How many of you are patients? Have family members who are patients? And yet all day we've been talking about us and them patients. Well, from my standpoint as a leader of an organization, I want you to bring your patientness with you to everything that we do, everything we design, every way that we think about what we're going to do in research and what we need to learn. So that patient-family member partnership is hugely important. We're in the process of this, I think it's an uphill, I'm not sure I'm going to say it correctly, Sisyphusian effort, which is to eradicate words like comply and adhere and things we do to people or for people, instead of thinking about what we do with the people that we're serving. So this redefinition of partnership, I think, should be, is core to the work of PCORI. And, you know, whose outcomes matter any less in looking at mental illness? There is only one measure. Do you feel better? Are you functioning better? Orthopedics, can you get around and move the way that you want to? Parkinson's disease, are you free enough of the symptoms of your illness to function the way you want? Those are really the only measures that matter, and we still know far too little about them. So the number one partnership I wanted to call out, and I don't think we've talked about it enough today. Second, we think that partnerships, and Paul referred to this, it's the interrelationships that need the work and definition. We've done a lot of work with the HMO Research Network. That's great. With Portal, that's great. We have a little more close to home experience with 2 organizations that we have helped create. We've been the catalyst and sponsor for 2 public-private partnerships that I think are important to the conversation today. One of those is ICSI, the Institute for Clinical System Improvement, which involves all care delivery organizations in sharing information and doing research that leads to quality improvement. And I think that's been an important one because we do agree on sharing our information publicly. We do agree on the importance of transparency. We do agree that we can measure quality, and we know it's a journey, but we've been doing that for the past 15 years. We've also been the sponsor and creator for an organization called Minnesota Community Measurement that delivers performance metrics directly to consumers in the state of Minnesota comparing quality. Now that's been a little bit of a difficult journey, and I know one of the comments that the group in planning wanted me to make was, what do you do when your results don't look so good? We had that experience. Our orthopedic department ended up not looking at the top of the list, and it was a very difficult conversation to talk about reporting results when the results aren't what you would wish for. But the conversation ended with, no one protects you from your results. There's no way other than trying to conceal or drop out or not participate in Medicare that sooner or later your results are going to be plastered everywhere. And so we felt it was actually an advantage to get out in front of that. So I wrote these nice words earlier that research, performance improvement, operational redesign, and performance measurement, which I consider all in an area that's kind of blurry as to what the limitations might be of each of those topics, are core. But I realized I wouldn't be telling you the truth if I said that, because I spend probably 80% of my time on performance improvement, operational redesign, performance measurement, and not very much on research. When I've looked at where our dollars go, I've preferentially funded those things that have led to performance improvement. Why? Because the time frames are too slow for most research, and the obstacles that have been noted in the previous discussions stand in the way. Too much of the knowledge that we've already created isn't being put to use. And I just have had to say, I think we need performance change and time horizons that are much more rapid than those created by the research structures. Not to say we've decided research is unimportant. It is important. It's just that it's not as important to me right now as the performance gains that I need to see as we look at delivering on that triple aim. So I'm not sure exactly where to go from there. I think alignment, better alignment of our performance improvement initiatives with our research initiatives, really important. We're working on that. We clearly don't have it nailed, or maybe we'd be making some of those decisions a little bit differently. We're working right now on our Partners for Better Health Goals 2020, long-range stretch goals structured in the triple aim, and we're using those everywhere in our organization, from our education focus to our research focus and in our operations. I hope that will help. I think it should help. And I also would say that we've got a big focus on making it easy to do the right thing. I'm concerned that when we get research results, we don't have a way to make them come to reality in our delivery system very effectively. So we've done some things that I think represent a start. One is this ICSI and Minnesota Community Measurement, those public-private partnerships. The nice thing is all the health plans in the state support those entities. So sometimes when we figure out what a good path is or quality improvement initiative, what it might be, or a system to support, all the health plans in our state can do it the same way. We can make a pretty compelling case to physicians across the community that instead of seeing it done 5 ways or 4 ways, we'll do it 1 way. So we can make it a little easier to do the right thing in that environment. We also have an initiative called Click Reduction. It's what we consider a commitment to the physicians in our system, that as we put in new approaches, redesign care, that each time we'll look at how we can reduce the number of clicks it takes to do the right thing. So big focus on making the right thing easier to do. Also huge reliance, and this is where I think operational change is too slow, in using our electronic health record decision support approaches to make it simple to actually bring new knowledge into action in our delivery system. So that whole role of execution and capably executing is really a big deal. We also know that in terms of physician time with patients, that's really got to be the most important pivot point for the relationships built on trust. That happens physician, patient, hopefully not always in an exam room, hopefully sometimes in workplaces, hopefully sometimes in group settings, often online. But we also know we need to redefine the role of other caregivers. And so a lot of time and focus is going into what's the new role for the pharmacist. We have 4,000 patients who are taking more than 15 medications. Actually, the most important relationship for some of those patients might be with their pharmacist. So really looking at how we can redesign to be more effective. I was fascinated to hear that others are still also tackling some of these challenges of thinking about knowledge and knowledge hoarding. Actually, knowledge hoarding is just a foreign thought to me. I feel like we have too much knowledge, and our challenge is using that knowledge. I think of Beth's studies from many years ago. I happened to run across some of my PowerPoint slides when we were talking about the work to implement what we know works. And I'd be interested in finding out how much improvement has there been in that intervening 10-year period of time to actually use the knowledge that we have today. So I don't feel like we're at risk of too much hoarding. I feel like we're at risk for effective implementation. So to circle back and close, I do feel optimistic. I think we are just at the beginning of figuring out how to partner with patients. I have a little different perspective on what patients will bring to us, and frankly, I'm one of those people who doesn't even love the term patients. But we've noticed in our state and our region a reduction in performance on women using preventive services as recommended. So we've been improving, flattened out, looks like a little deterioration. We thought, well, we won't do any formal research. We'll just try to get some focus groups together and find out what's going on. And the answer we got is, you've confused us. We don't know who or what to believe. I don't know when I need a mammogram because you give me different messages. I finally got that I should have a pap smear every year, and now you're telling me that's wrong. I'm already worried about my kids and whether immunizations are safe for children. So we have, through all the knowledge that we've created, we've confused our patients and consumers to the extent that even care that would be beneficial is sometimes not being used. So I think the opportunities are to connect in new and different ways with our patients, to remember they come to us with knowledge and beliefs. I think one of the opportunities is actually understanding better what health behaviors, how health behaviors can be affected. I think patient councils is only a beginning step, but in our case, we used a patient council to ask some questions about physical space redesign for mental illness care. What we ended up with was not just a different physical space. we ended up with an entirely different care model for mental illness care as a result of the input of patients and families. We know that 80% of healthcare in our country is chronic illness based, and how much of that relates to healthy behaviors. Again, I worry that sometimes the research that we're doing addresses not the basic things. If it doesn't come with a device or a product associated with it, if it comes with a walking recommendation, it's viewed as uninteresting. And yet that might be the single most powerful thing we could do in our healthcare environment to change healthcare outcomes. And so finally, I think the different languages and the different professions and the different hierarchies associated with performance improvement and research really stand in the way of us making much needed progress in truly delivering on our potential for the people that we serve. So thank you.